Thanks for joining us for another edition of DermTube Daily Coverage. I'm Joel Cohen. I'm a dermatologist in Denver, Colorado, and we are with Joel Gelfand this morning, who is a dermatologist and also a member of the Department of Epidemiology at the University of Pennsylvania. His expertise is comorbidities in medical dermatologic issues, and he spoke about comorbidities in psoriasis. Can you tell us some of the salient points about your presentation?
Oh, Joel, thanks for having me here today. It's a pleasure to speak to you and your audience about these important issues. So my work is mainly in psoriasis, understanding what happens to a patient when they have psoriasis for decades. And what the research has shown is that for patients who have more severe disease, the kind of patients we treat in our practice with ultraviolet light or methotrexate or biologics, these patients go on to have higher rates of heart attack, stroke, cardiovascular death, and diabetes, independent of traditional risk factors. So it's not necessarily driven by whether or not they smoke or overweight, but the disease itself seems to drive higher rates of these major medical problems. And the culmination of this is that people with more severe psoriasis die about 5 years younger than they should, based on what their other risk factors are for mortality. So this is a very clinically important area for our patients, very clinically important area for our colleagues in dermatology to be aware of, so we can educate patients appropriately and try and bend the mortality curve for our patients with more severe disease.
So we know that genetics clearly play a very important role in exactly some of the endpoints that you're discussing. In terms of areas where we may be able to intervene, so smoking, weight loss, hypertension, you have specific advice for folks out there in practice who are seeing patients and trying to really counsel them on the importance of really getting these parameters under control?
Yeah, so I think it really starts with, just being a doctor, and being a doctor means educating the patient. So the first part is really just explaining to the patient, what does it mean to have psoriasis? When a patient comes into a practice and has diabetes, there's a whole educational arsenal that comes at that patient from nurses and the providers and what have you to explain what the disease is about, what to expect over time. In psoriasis, our patients are often left on their own to understand their disease. And so the critical part is first educating them. For patients with more severe psoriasis, we educate them that they are more prone to diabetes, more prone to heart disease. And then the most effective thing for many dermatologists is to encourage a patient to see their primary doctor for the appropriate age-appropriate cardiovascular risk factor screenings. In my practice, we often take a blood pressure on all of our patients. We pick up a lot of undiagnosed hypertension in psoriasis patients. I will screen for diabetes with a simple hemoglobin A1C. This is an easy thing to do, and I pick up a lot of undiagnosed diabetes. And really the challenge for a lot of us is that although our practice is very busy and may be difficult to add these additional screenings into our routines, for us, we may be the only doctor taking care of this patient. Patient's 30 or 40 years old, they think they're relatively healthy. They're not going to go see a primary doctor for how these things done. It's psoriasis that matters the most to them. And often our patients think that we're a physician and that we would be checking things if they need to be checked. And so I do think there's an important part for us to play a role in this area, really for helping our patients have better health outcomes.
So from a cardiovascular standpoint, this is one of the most concerning features of this specific cohort of patients. So when do you work more closely with a cardiologist, and how do you get these younger patients on board?
Yeah, so it's interesting. In my practice, I'm at a quaternary care medical center. I have a cardiologist who I collaborate who's very interested in this area. People in the cardiovascular community are very interested in this area. We publish a lot of our papers in major cardiology journals. And there in cardiology, they understand that chronic inflammation is a major risk factor for cardiovascular disease. They're not surprised by these associations at all. And they're sort of used to thinking about treating risk factors possibly more aggressively in those who have these atypical or non-traditional risk factors for heart disease. So, they're used to treating people who have high cholesterol, high blood pressure, but for those who have additional risk factors, whether it be rheumatoid arthritis or psoriasis, oftentimes cardiologists or primary care doctors may try and be even more aggressive in lowering the patient's cholesterol, for example, to a more protective level for the patient. But of course, this really comes down to a discussion with the patient, their preferences for treatment, and their concerns for safety and future risk.
From one Joel to another Joel, we appreciate you joining us for another edition of DermTube Daily Coverage from Maui Derm 2015.